introduction to me. So my name is Jordan. I'm a lecturer practitioner and work in mental health. I've worked in mental health throughout my career, and I lecture at my uni, which is Bournemouth University, around occupational therapy. So I was trained in Plymouth University, was taught by Bex that time ago, and I graduated in 2019. I then went into working in an acute psychiatric hospital and did a rotational post there. So I was able to work in a few treatment wards, an admissions ward, a PQ unit, and an older person's ward. These are obviously mental health in the hospital. So at the minute I work in the Assertive Outreach Team, and I currently run a special interest group around the dark side of OT, which features sort of guests talking about their areas, which Bex was kind enough to come along to and present on one of them. So once I sort of graduated and was employed by in the psychiatric hospital, the first thing that sort of struck me there was the sort of disparity between the amount of service users that were substance use users, and there being no sort of support or any kind of groups that people could engage with around that. So the response to patients going out on leave and using substances would very frequently be taking away that patient's leave, taking away any sort of smoke break opportunities that they had, and essentially any recreational time, and there wouldn't be any effort to talk to the clients and to think about what it was that triggered that client to use. It was a very sort of black and white punishment based system, and this kind of led me to making a specific group around substance use. So that's sort of the protocol and the kind of vague session plan. So the sort of point of that was to allow patients the opportunity to talk about why they use substances and what it meant to them, to think about what were actually the positives that they found in using substances and what they found was meaningful in that as an occupation. And my hope there was to sort of start thinking about occupations that aren't necessarily intrinsically healthy or may not necessarily align with other people's values, but actually it's meaningful to those individuals nonetheless. And I think it was important to sort of to start thinking about occupation in that way, and to try and show that to the ward staff in any way that I could, so we could understand it in that more holistic way, I guess. So that way of thinking specifically led me to take a role in the Assertive Outreach Team. So the Assertive Outreach Team are we talked about Rat Park during the substance use group. I'll quickly go over that actually, because it's quite central to the AOT sort of mindset. So I don't know if anyone's ever heard of this, but there was a study made in the 1930s called Rat Park, wherein a rat was put in a very small cage with 2 water bottles. One was laced with either heroin or cocaine, and one was just normal water. And in the cage, the rat had no activities to engage in, no stimulus. It's a very small cage, no other rats, and it would basically drink the water with heroin or cocaine in it until it overdosed. And then Bruce Alexander came along later on and created what was called Rat Park, which was a big enclosure with lots of rats and lots of activity and lots of stimuli, able to satisfy their hierarchy of needs, and did the same thing. One water bottle was laced with cocaine or heroin, and one was normal water. And what he found was the rats would try the laced water, but then return to the normal water and just carry on drinking that until none of the rats were sort of touching the laced water. And that was something we talked about in the group to sort of illustrate that actually there's lots of reasons why an individual might engage in substance use, specifically to do with their environment. I guess to try and get people thinking about, what are the reasons that people are engaging in substance use, and could we sort of correlate that rat cage where rats don't have any sort of community or activity or stimulus or any occupational engagement, could we correlate that to some of the patients that were on our ward and that we were treating, to sort of push that mindset. Actually, it's about making adjustment to an individual's environment, including engaging them in occupations. So the Assertive Outreach Team is a service that was originally made in the US. So it was made specifically to support individuals that were at high risk from disengaging from services. So we accept people with a primary diagnosis of schizophrenia, bipolar, schizoaffective disorder. We also accept people with personality disorders, but we don't accept people with this as their primary diagnosis, as evidence shows that an assertive outreach approach isn't effective with these kind of sort of patients. Our patients usually also have a high rate of readmission to hospital. They'll frequently engage in substance use and possibly in risky behaviour. In terms of sort of accepting people into the group, we have a very sort of team approach, in that we're a team made up of psychiatrists, nurses, and OT support workers and social workers. We will all go and assess the patient, with our own sort of criteria, so we can build a really comprehensive idea of the individual and how we might be able to help them. So in AAT, frequently we come across individuals who engage in occupations, as we say, that are considered on the dark side. So that's to say occupations that are potentially unhealthy but meaningful to the individual nonetheless. And it's also important to consider the parameters of health and well-being, because that's quite a complex thing, I think, especially in how it relates to individuals. So that's something we're going to talk about a bit later. But for now, we're going to do like a little case study. So this was someone that I met in my last placement at Plymouth Uni, where I was working in a homeless shelter. Some of the characteristics of this patient would be quite typical of the patients we get in the Assertive Outreach Team as well. So we called this patient Stephen. So Stephen has been homeless for 30 years. He had lived at the shelter for 5 of those. Has a daughter that he hadn't seen in years. He'd also been a victim of modern slavery. He was a frequent user of heroin, and hadn't had contact with his family in a long time. Again, his environment didn't facilitate occupational engagement, so you can see the sort of correlation between that and the rat cage that was done in that study. So when we think about reasons that Stephen might have for using, so I did an interest checklist with Stephen, and an interest checklist, as I'm sure like lots of people are aware, is a checklist that has lots of different activities on it, some of which are quite like niche activities. It would be sort of abseiling, snowboarding, rock climbing, quite extreme activities, I guess. And I was completing this with Stephen, and we were both sort of, finding the humour in it. I was asking him if he ever wanted to go rock sailing, or if he ever done that, if he wanted to go snowboarding or abseil. And he said, I haven't ever done any of these activities and don't think I'm ever going to do any in the future. So I sort of said, okay, well, what is it that you find meaningful then? What's your occupation of choice? And he said heroin, without a pause. He said heroin, that's my occupation. That's what I get up in the morning thinking about how I'm going to get. That's what I go to bed at night thinking about how I'm going to get. So obviously as a student, I thought, how am I going to get this man to come off heroin and start, doing gardening or making cups of tea or cakes, all those nice typical OT activities. But then I started to think about, after chatting to a lot of my lecturers, actually heroin can be a meaningful occupation in and of itself, even if it's not healthy. If that's what's meaningful to Stephen, then sort of who am I to say that's not a completely valid and meaningful occupation? So thinking more about that, I started to think about what are the reasons Stephen had for using. And we can break down drug use as well, with Stephen in particular, into 3 separate categories. So we can have using, dealing, and scoring. Scoring being going to get the drugs. So if we think about reasons for doing these sorts of things, there's a few here that I've collated, and you'll see differences and sort of similarities along them. So a lot of these things, I think, are things that anyone can relate to. I certainly relate to a lot of these things, like boredom, sleep, wanting to have a community, acceptance, isolation, loneliness, enjoyment, pressure, acceptance, respect. I think these are all things that we can recognize that we all sort of crave or want at some point in life. So when we think about the skills that Stephen's using to complete these sorts of activities, we see that there's actually lots of transferable skills that we can sort of extrapolate from that as an activity and transfer into something that's got more, that's got more sort of more of a long-term application to it, if that makes sense. So thinking about drug use, Stephen had to be aware of his time, especially if he was scoring drugs for himself or other people. He had to be observant, aware of what's going on around him, as obviously it's an illegal activity. So he's got to make sure he's not caught by the police. He's got to manage his money, especially if he's selling drugs to people. He also had a leadership role within the group, as he'd been doing this a lot longer than a lot of the other residents, so had a sort of protective role there in helping them use safely and telling them who was sort of good to buy drugs off and who was dangerous to buy drugs off. Had a lot of resourcefulness as well in creating contacts. And these are all skills that we can see in lots of different areas. So just, to name a couple, being a salesman, being a team leader, these are all transferable skills that we can transfer from potentially engaging in something that's not as sustenance as drug use, and maybe into something that has a bit more leniency to it. So thinking about like health and well-being, excuse me. So there's sort of a lot of different parameters that make up health and well-being, and it's important to understand, I think, the dynamics between them. So we frequently sort of focus on the area of body functions. Is that something that we can objectively measure? We're either healthy or we're unhealthy. We either have an illness or we don't. So it's more able to be purposefully treated, especially in the sort of NHS settings. But psychological and emotional health and well-being is a lot more subjective to the individual. Then that can be attributed to intrinsic values rather than something that's sort of globally applicable or measurable. So occupations that provide a sense of purpose, meaning and life satisfaction, but ultimately damaging to our bodies, can be viewed on as negative. And occupations that are healthy in some frequencies can be viewed as positive. But actually these, I feel like, exist on a healthy and an unhealthy continuum, like a spectrum, rather than just being sort of black and white. For example, there can be benefits to drinking alcohol in a social situation, as I'm sure many of us know, even though that's inherently a poison that we're putting into our bodies. So here we have like a discrepancy between something that's positive for our psychological and our emotional health and well-being, but detrimental to our physical health and well-being. On the other side of that, you can have an activity that's inherently healthy, like hand washing, but that can become the sort of subject of maybe repetitive behavior if someone has something like, let's say, OCD, and then that becomes something that's actually physically unhealthy. If you're washing your hands constantly, you're going to rub away the skin. It's going to become something that's psychologically a torment for you. So I think it's just to sort of put in perspective that I think when we say health and well-being, it's there's quite a sort of complex relationship with individuals and that as a concept. And certainly in the Assertive Outreach Team, I think that's something that we always have to bear in mind. Like self-harm is another example. Self-harm is something that's physically damaging to the body. But people that have worked in mental health will know a lot of people that engage in self-harm have used phrases like relief or a release when talking about self-harm. So in that way, it's, the relationship between that and health and well-being and the individual, again, is a really complex one. So it's not as easy to say, I think, an occupation is healthy or unhealthy, because, with that sort of relationship, it is very dependent on the individual and the specific context. So in terms of thinking about the approach that we take in the Assertive Outreach Team, something like I call that it's called the push and the pull. So this is thinking about positive risk taking and emotional intelligence. So frequently when working with clients, I come across a scenario in which their occupational interests and goals, we've discussed these and created a plan and an intervention, and a client may not want to go through with this intervention due to anxiety, the effects of their mental health or medication, or just demotivation. Excuse me. And at this point, as therapists, I think we need to judge when to push or when to pull. So our clients, sort of, whether it's going to be beneficial to push our clients to go through with this intervention, or if this is going to harm their overall rapport and therapeutic relationship with us. And I think the way we interact with our clients provides obviously a sort of clinical foundation of how we can move forward with their interventions. So do we encourage them to enter a situation that they potentially feel uncomfortable in and undo the sort of positive skills and rapport we've built up so far, or do we do we acknowledge that to push them into that sort of or do we acknowledge that actually sometimes that's what that person needs? They need to be pushed into a situation, maybe in a more of an assertive way. But finding the nuance of knowing when to do that, I think, is the hard thing. And it's important to sort of acknowledge that when neither of these tactics are being used, we sort of enter a stalemate, I feel like, with our clients, where we're sort of not taking any steps forward, but we're not sort of pulling back too much. We're sort of stuck in this nether region where we can sort of lose focus of what the goals are and the trajectory in achieving them. I think both pushing or pulling require sort of additional work to either reflect and encourage a client after being in a potentially uncomfortable situation, or working towards what a client needs to build on the skills that they've already made. So that's the first thing I think I use in the Assertive Outreach Team with my clients in particular. Another thing I think I use a lot as well is narrative reasoning, which is essentially the format in which we sort of disseminate information from our clients. It's their life story. Without narrative, all we have is just a series of facts. It's the client's story that brings them together and helps create a picture, I think. So when meeting a client for the first time, we will usually do an assessment, whether that's an interest checklist or an initial assessment or an OKRs or any of the assessments that we use. I find typically with my clients that's not a effective way to go. As soon as I sort of get out any sort of assessment paperwork, I'll be met with an immediate shutdown of engagement. I don't want to be filling in these things. I don't want to be doing this assessment. So it's a very roulette move to bring out an assessment, I think, with the clients we have. So how do we ensure our patients' narratives are being incorporated into our treatment if they're not accepting of our assessments? I think the best way to understand someone's narrative is to ask them, is to just show curiosity and willingness to hear about their life and what they find meaningful, the experience that they've had, why do they take a certain drug, Why are they happy to meet in a coffee shop but not in their own home? Why would they meet occupational therapists and support workers but not a psychiatrist? It's like a sort of jigsaw puzzle that you and your client need to put together to get the full picture. And I find the best way to do that is to just talk to the client. Maybe an assessment is a good catalyst to getting there. But I think I found a lot more success in just being sort of empathetic and using my listening skills rather than writing down, as I say, a series of facts that are useful by themselves, but not when they're unstrung, if that makes sense. So I find after sort of working to understand someone's narrative, occupational goals will jump out of the conversation. Even if it's subconscious in the client's part, they will find a way to tell you what it is that they need from you. I think a checklist can provide the opportunities for them to sort of to engage in certain activities, but I think, under the right circumstances, what the client really values will end up just coming to the forefront. And as occupational therapists, we obviously use our skills to be able to deduct that. I think it's a bit like it's detective work almost, like what's going on in the client's story, what have been the challenges and how have they overcome these challenges, who are the other characters in relation to the client, are they a hindrance or are they a help or are they both? Are we starting halfway through the client story or, where we meet the client, or do we need to go back and actually, look at things from the beginning for things to make sense? And I think we also need to be aware of what's realistic for our clients. I had a gentleman who wanted to hold down the job and also wanted to continue his occupation of using substances. And obviously these are sort of two things that are slightly at odds with each other. He's not going to be able to hold down a job if he's on a come down every day or if he's under the influence. So what we did is worked out a plan of, okay, well, let's timetable your drug use. If it's something you're not going to stop, which isn't ideal, but things rarely are ideal in these sorts of in this work. So let's timetable your drug use. Let's think about what days you're going to be working at this job, and we'll timetable your drug use so you're not taking drugs on the day, you're not taking drugs the day before, so you've got time to relax. And sort of using this system, we're able to work out a little bit of a schedule for this gentleman, so he was able to engage in his occupation of substance use, but also to be able to engage in work, which is something that he was really he found a lot of meaning in as well. And as I say, it's not the ideal situation, but it's the realistic situation. I think it's about sort of thinking about how do I find a place of balance between what my values and the client's values, and sort of negotiating it, I guess, coming to a sort of agreement, but being respectful in how we do that as well. I think something else is really important to bear in mind as well is our own sort of biases, our own bias that we have, because I think it can come into a lot of the clients that we treat without us being aware of it. So just briefly, because the shadow is a concept by Carl Jung, which is more of a psychology concept, but I think it sort of illustrates this quite well. So it shows how we carry an unconscious bias and assumptions with us all the time that we're not aware of. So you can think of the shadow as an almost invisible bag that you have over your back, and as you go through life you will put certain things in that bag, and that usually comes from sort of negative experiences. So if you have parents that are particularly harsh or angry to you, you might put anger in that bag and think that's an inherently negative emotion that I shouldn't feel towards other people. But the trouble with that is it's not an inherently negative emotion. There's times when anger is the right response to something, or it might be useful in something that you're trying to achieve if you do it in a way that's obviously contextual. So people go through life, I feel, putting certain emotions and certain mindsets in this sort of shadow bag, and it ends up also taking large parts of just your personality with it. If you're taking away your ability to be able to feel any sort of anger, then you're taking away your ability to be able to be potentially assertive, or to stand up for something that you believe in when it requires it. Not all the time, but I think there's certainly aspects of those different emotions that have overlap. So we all create unconscious bias towards people and occupations through this process. And we will see it if we examine our behavior patterns and how we treat certain people and react to certain people engaging in occupations that don't align with our sense of value. And it's important to be aware of that, not sort of explicitly everything that's in that shadow bag, but just aware that it exists, I think, is enough to be able to approach things in a lot more of a self-aware way. So that way we can examine sort of patterns in our own behaviour and create a bit of a blueprint in sort of how we interact with the world and also how we interact with patients. So I think this is especially important when working with clients who frequently engage in behaviour and occupations which may not always align with our own values. Because a client will, sniff that off a mile away. Like, everyone has known people that they've seen acting in a certain way, and it's really obvious to us, and that person's very unaware of it. The person, says, "Oh no, I don't have anything against this or that. I just think this." And to us, it's very obvious that there's something inherently that person doesn't like about whatever it is that they're interacting with. But that person is completely unaware of it, and it's the same to us. When we have those sort of subconscious biases, it's completely blind to us. We don't see those biases, but it's very obvious to everyone else because they can see things from an objective perspective. And likewise, our clients are going to see that on us. And it's, think about the sort of damage that does for any potential rapport you can build up with people. So I think in that way, it's a really important thing to be aware of when working with these sorts of individuals. On the contrary of that, I think the nice thing about OT is, as a profession, it's something that you can bring your personality into. The type of therapist you are is going to depend on your personality, your skills, your interests, and that's something you can really bond with over service users as well, and something I've found very beneficial. So I do music outside of this, outside of working in the NHS, and I've just by chance found that like 75-80% of my clientele are really creative musicians, or really want to be involved in music in some form or another. They didn't have an opportunity to do that, certainly not in a sort of group community setting. So we sort of partnered up with a local music studio called Absolute Music, which has access to sort of studios and instruments. And we're able to use that once a week to run a music group where patients have access to practice rooms that we all do as a group, access to instruments and studios, so we can sort of actually record music as a group or as individuals, and sort of release that under our own name that we have. And that's something that we've got funding from the National Lottery, which is amazing to sort of start building it up in other places as well as here in the south. We've kind of got it going on in the west as well. But I think it just goes to show that people really, once given a creative outlet, even if the diagnosis that they have or the team that they're under suggests that these patients are hard or won't engage or don't want to engage, actually it's just about finding that occupation that service user feels that they can express themselves within, and also being able to sort of come alongside them in a non-judgmental manner, where someone feels they're actually able to work with you in a really holistic and sort of client-centered way. So I thought it'd be nice just to end on that as a bit of a positive in working with these clients, and actually that the people under the Assertive Outreach Team are some of the most creative and sort of friendly clients I've ever worked with. They just find it a lot harder quite often to trust people with that. So yeah, so these are a few references I've used, which are I would recommend you read. There are a lot of really interesting books and journals here, including Bex's book as well. Yeah, and that's my presentation.